and we will begin the modalities to help the recovery process. So take it away, Deanna.
Perfect. Welcome back, everybody. You're probably wondering why you have a cup of ice or cold water. I promise we'll get to it. It's exciting. Session 3, modalities to help the recovery process. And let me preface this with, number one, I'm just briefly touching on a few modalities. I don't advocate for one over the other. I just feel that the more knowledge I can arm you with, the better equipped you can be going forward. Whatever you choose to use, don't use, take what you want, leave the rest. Just truly understanding that there are several different modalities that can help an individual in the recovery process, not just the individual, again, who's dealing with the substance use disorder, but the family member as well. There's modalities out there for us too. Dysfunction junction. What's your dysfunction? So dysfunctional thinking, it's a process that disregards facts and believes in falsehoods. This is the opportunity in the presentation where I truly want you to stop and think about what processes you may have personally, not your colleagues, not as a whole, but you individually. What process do you have already hardwired, ingrained, that might lead to dysfunctional thinking? And we're going to go through some of the dysfunctional thinking overview, a high-level overview of dysfunctional thinking. When I say I'm way out of my element, I don't put myself out there that I am a master's in social work or anything by any means who understands this process way better than I do. This is my nurse brain, my nurse background, and my parent brain coming in and me researching on my own, truthfully, these things that I have found. So thinking that through, what process do I have that may lead me to dysfunctional thinking? So what are dysfunctional thinkings? There's actually 10 distortions that we can identify. There's way more than this, but we're gonna, for time's sake, gonna narrow this down. 10 distortions in thinking. You either have polarized thinking. That's where you see everything is all or nothing. It's black or white. We think in extremes. There is no gray. It's either this or it's this. Overgeneralization, meaning setting a rule after an event or series of events, using the words always or never. He's always using. He's never sober. We often see where it's associated with PTSD or other anxiety-related disorders. Catastrophizing. I'm a pro at this. I'm a pro. Always assuming the worst and dread. I am always waiting for the phone call to tell me that my son has overdosed or my son's in jail. It's 0 to 150, like that. I'm a perfect catastrophizer. Personalization. Assuming that things are personally connected to you or caused by you. It's associated with heightened anxiety and depression. Somebody's whispering, they're talking about me. I'm assuming they're talking about me. I'm taking that personal. Mind reading, assuming that you know what someone is thinking. It's often difficult to distinguish between mind reading and empathy. This is where a lot of healthcare providers get caught up. Perceiving what someone is feeling. There's a fine line between mind reading and empathy. Mental filtering, ignoring positives, only focusing on the negatives. We often see this in emergency department and clinic settings due to the amount of trauma that is seen on a daily basis. Right here is the slippery slope to leading to the loss of empathy. Mental filtering, I have to filter it out. I don't see the positives, I only see the negatives. discounting the positives. It's a negative bias thinking. Explained away as being lucky, a fluke. It reduces motivation and cultivates learned helplessness. Should, shame, often chastising, seen in internalized family dynamics and cultural expectations. Well, I'm going to shame them to get clean. I'm going to shame them to be sober. How could you do this to your mother? Emotional reasoning. False belief that your emotions are reality. There's no rational evidence for the emotion. We make it become my reality. My reality, my emotional reasoning is grief all of the time. Labeling, reducing self or others to a negative characteristic, basing a judgment on a single event or behavior. Just an addict, just a junkie. They're a drug seeker, frequent flyer.
Yeah.
This is really where I want to stop for a second. What are some of the other terms that you've heard in your daily work with other colleagues or whatever to really understand labeling? And let's thinking about going back to dehumanization. What's one of the key components of dehumanization? It's labeling. So I'm going to stop sharing my screen and have that moment for open dialogue. What are the other terms? I named off a few. It's just an addict, just a junkie, another drug seeker, or frequent flyer. What are the other things that you're hearing? Let's be vulnerable.
User.
Hmm? Some of the other ones I've heard from colleagues, mind you, these are professional colleagues, MDs, nurses, the works, waste of time. Wow.
I see people using the diagnosis as a label. So like saying, well, they're a heroin addict or they're borderline personality, and kind of writing them off that way because of what they've been diagnosed with.
Yep. Even in that own subset of population, my son refers to himself as an addict. He labels himself. That population is labeling themselves. That was a great one. Any others? Come on, I'm going to make you use your ice before I intend to make you use your ice.
I think the frequent flyer, I know I always heard that a lot in the clinics that I've worked in, or just, I think it's the prejudging sometimes is worse than the labeling, but, oh, I know what they're here for. It's immediate. I see this person on the appointment. I know what they're here for. Or sometimes it's, I mean, not to sound bad, but back pain can be a legitimate thing, or headaches can be a legitimate thing. But it's if they see that, oh, I know what they're doing. They've never even seen the patient. This is primary care providers, never seen the patient, never seen the person. Oh, the problem issue is back pain or migraine or something. Oh, well, it's already, the judgments are already made.
Absolutely. You're absolutely correct on that, Elizabeth. So then how does that affect how we treat them, right? I could have an MI walking in the door that says they've got back pain. And if I'm blowing off as back pain because they've been here, 25 times and you're referring to them as a drug seeker, and it's back pain, guess what? I just missed an infarct.
Right.
This is the slippery slope. This is where we get caught up.
And this is really hard when you're working with critical access hospitals, FQHCs, RHCs, because they're the safety net. So then this is the only place these people have to go, but yet how are we caring for them and are we really meeting their needs? I'm going to, I'm going to start saying names here, but I want to hear some more labels. So we're going to give somebody else a chance to say, but share with us a couple more labels, stereotypes, or anything that you've heard.
Well, I know for family members, we hear the term, just no matter who it is in the family, they're all enablers. That's a label for a lot of folks.
And I think that's good because when talking about how we have to provide the whole family with resources, we also can't prejudge the family because I've done that too. Well, those people weren't the parents we thought they were. That's went through my brain, that type of thing, So I think that's important too, to say that they're not, giving those family labels.
Absolutely. And I would emphatically agree with that. If I've been told once, I've been told 100 million times, you're enabling, you're enabling, you're enabling. And that's hard. That is a label in and of itself. Or I wouldn't do this, or you should have kicked him out. It's again, that shaming. You're shaming me for how I'm dealing with this and how I'm parenting, or how I'm trying to just have activities of daily living and be somewhat functional and normal. I'm being shamed.
Shaming for caring.
Yep. Absolutely. Well, we can go ahead and move on to the next slide. Thank you for those people that did share. But just keep these distortions in thinking and in your brain as you move forward through your career, professional life, and on a daily basis. Catch yourself saying, oh, wait a minute. Am I polarized? Am I overgeneralizing? Am I personalizing? Am I labeling? Just stopping to have that dialogue with yourself. So what are some of the modalities that can kind of help in these distorted thinkings? CBT, or cognitive behavioral therapy, is one of them. This is often used and coincides with a lot of different other treatments, but really getting down to what the behavioral piece of this is. Some of the questions that are asked during CBT, or cognitive behavioral therapy, is to change the distorted thinking. Is the thought helpful? What is the disadvantage of thinking this way? Is it really in my control? Am I making an assumption? Can I look for shades of gray? Am I holding someone else to an unreasonable expectation or demand? Is it really all someone else's fault? Am I making this personal when it really isn't? That person that comes into the ER or the clinic who is in a rage, or they're hateful to you and they've spewed every hate word out of their mouth to you, do I take that personal, or am I trying to understand and get behind what's really behind all of that?
Hold on a second. Are we supposed to be seeing a PowerPoint or just a speaker? It doesn't matter to me. I just want to check.
Thank you. No, you are supposed to be seeing my PowerPoint. I forgot.
Okay. I thought you were going down a list, but perfect. Okay. Thank you.
No, thank you for letting me know, because I was just buzzing along. Is this way of thinking adding value to my life? If I was a lawyer, how would I argue the other side of the thought process? That's just a brief summary again of CBT, cognitive behavioral therapy. One of the things from a family perspective that I've spent a lot of time researching, I often would ask when I get overwhelmed and am just chaotic with what's going on with my son, where's my rehab? I want to check in. I want to put everything aside. I want people to take care of me. Where's mine? And really understanding that it really isn't there as far as family members go. There's a few things here and there. What I found to be most useful from a family perspective is utilizing craft. And while I mentioned this is, yes, it's geared towards family. This approach, once you learn it and understand it, is not just for family. It really is for you guys, the clinicians, the providers, the doctors and the nurses, changing our language and how we interact and deal with individuals in the moment of active use, non-active use. It's been a great tool for me. So what is CRAFT? It's community reinforcement approach and family training. It's an intervention that is scientifically evidence-based, and it was designed to help concerned significant others or family members to engage in treatment versus refusing substance abusers into treatment. It is a new intervention method that was developed with the belief that family members can and do make an important contribution in other areas of addiction treatment. That I and a concerned significant other can play a powerful role in helping to engage my son or the substance user to seek treatment, to get well, to help him recover, to be in remission. I had the absolute pleasure last week of speaking to the individual who created this modality, Dr. Robert J. Myers, and we had a 45-minute one-on-one conversation. He taught me what he could teach me in his 45 minutes, and just being able to bounce off, how do I feel as a healthcare provider? How do I feel as a mom when these roads are intersecting? And what is there for me? Both as a mom and as a healthcare provider, and really just drilling that down. So I just wanted to give a brief introduction. There's multiple trainings over CRAFT. You can become certified in it. Utilize some time after this presentation and really check into that. Dr. Myers will accept emails. He was gracious enough to accept phone calls if there's additional questions that you may have. What does CRAFT do? It increases family compliance with an intervention for persons with substance use disorder. It increases the rate of engagement of addicted individuals into treatment. It includes motivation building, communication skills training, treatment entry, and safety training. That piece right there is why I would promote it for emergency departments and rural health clinics. Because we can all use help in that. And if we just learn a new tool as far as communication goes, then it's only going to be beneficial. It provides education to families or caregivers on individuals' disabilities or illnesses. It identifies stressors and demands. It connects individuals with others in similar roles, develops skills to access community resources, and develops effective strategies for communicating effectively with healthcare professionals. It is evidence-based. It's been studied. There is research and science behind it, where if you utilize the CRAFT methodology, they can show where they can get an individual who is in active crisis with use, who has families or concerned loved ones or others in the background using CRAFT modality versus those that don't. The ones using CRAFT modality, oftentimes there's a 70% increase that individual will go into treatment by simply just changing our communication and using this type of language. When do you engage? When don't you engage? What language do you say? What does that look like? So this is you need your ice. Everybody needs their ice. For those that can be on camera, let's be on camera. This will be great. This is talking about DBT. We talked about CBT. Let's talk about DBT, dialectical behavior therapy. What is that? It's moments. This will be very helpful for you in the rural health clinic and emergency department setting you have individuals who are coming in, they're in active crisis at the moment, they're angry. The situation may be unsafe for us. It may be unsafe for them. It's those patients that are throwing fits or whatever it is. You've got security standing by at the room. Using methods of DBT, dialectical behavioral therapy. There's 4 core components to DBT. Mindfulness, interpersonal effectiveness, distress tolerance, and emotion regulation. So mindfulness, just looking at the clip here, is my mind full of all of this junk, or am I being mindful? Understanding the difference between the two. Interpersonal effectiveness, it's skills that help us attend to relationships, balances our priorities versus demands, balances the wants and shoulds, builds a sense of mastery and self-respect. The objective is you're going to clarify what you want from your interactions with other people. You're going to identify what you need to get the results you want. Distress tolerance. These are little tips and tricks. When you have that patient, or even you yourself, my heart rate's increasing, I'm feeling flushed, I'm in an anxiety-ridden moment. And when you're in those moments, we all know our brain has a one-way track. It's going to continue to build on that anxious moment. It's just going to build and build and build and build. So these are tips and tricks in DBT that you can use for yourself. You can use it for patients. I wish I would have known this years ago. I would have used it. So everybody get your ice. I've got my ice. So what I want you to do in this exercise, and describing distress tolerance, and a very quick tip to get your brain from being super anxious to somewhat calm, is I want you to think of, I'm just gonna say unrest. We're gonna say unrest. Think about a war, maybe. Like you're in a combat situation. I'm fighting. I've got my fight or flight mode activated. That's what I want you to think about. Think about all of the horrific things that go on with that. We're thinking about fighting. I have to stay alive. I've got to protect myself. People are shooting at me. People are coming after me. Just keep thinking about that until we activate that fight or flight. So oftentimes this is where you see your patient at. Now I want you to take your ice or your glass of cold water, stick your hand in a glass of cold water, whatever it is. I've activated my fight or flight. I'm going to hold my ice as it melts in my hand. I'm going to keep holding it in my hand. And I'm going to still sit here and try to think about, for a few seconds, I'm going to think about being in a war. I'm thinking about they're coming after me. They're shooting at me. I'm trying to activate that fight or flight. I've got to protect myself. I'm safe mode. The feeling, feel great. Continuing to talk about it. Going to continue to talk about, at this point, my hands are freezing cold. And my brain is finding it hard to focus on that anxiety-ridden moment. They're super, super cold right now. Super, super cold. I want to drop this ice, and that's really all I can think about. Okay, you guys can let go of your ice. Take your hands out of the cold water. That's just a really quick, in-the-moment trick. You're in that fight or flight mode. You can use it on patients. You can use it on individuals. It's no different than the deep breathing exercises that we often say. You're going to breathe in through your nose. You're going to hold it for a count of 4. Then I want you to blow out your mouth like you're blowing out a birthday candle for a count of 8. It's just stopping that parasympathetic nervous system, putting that jolt all of a sudden in there and breaking that thought process. Because then my brain is functioning on the fact that that ice in my hand is super cold. It's hurting my hands at some point because it's so cold. I can't continue to keep this one-way thought process going. That's what you guys needed the ice for. But work with it. Look at this modality, study it, use it. And that simple ice technique then eventually leads to the fourth key component, which is emotion regulation. Motivational interviewing. Most of you are probably already doing this and have been through either IDOH's motivational interviewing or Elizabeth or wherever. But motivational interviewing expresses empathy through reflective listening. I'm hearing you, and then I'm going to repeat back to you what you're saying to me so that I can understand it. Did I perceive this correctly? It developed discrepancy between clients' goals or values and their current behavior. It helps to avoid arguments and direct confrontations. We adjust to client resistance rather than opposing it. Support self-efficacy and optimism. And it uses the acronym OARS by using open-ended questions, affirmation, reflective listening, and summarizing. Another modality is trauma-informed care. We're hearing more and more about this. We're getting better and better about trauma-informed care. We're getting better about understanding post-traumatic stress disorder, ACEs, adverse childhood experiences, thinking back to Generation O that I talked to you about. There's going to be a whole generation that's going to need this trauma-informed care. So if we're ahead of the game and can arm ourselves with the knowledge and the background and the research behind that, it'll be better off for that generation. What's really important here is that I really want to drill home and make a point about, especially in trauma-informed care. There is a difference between acting bad and acting injured. It is imperative for us as humans, as healthcare providers, as a society, to understand this difference. There's 6 key principles in trauma-informed care: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. So what are the tools that I can use? Some tools for use. Some of the tools I've provided some links here for you as well. ASIS, Adult Substance Use Survey. Audit, Alcohol Use Disorders Identification Test. CAGE, AID, most often used. It's very brief. CRAFT, we just talked about one CRAFT modality. This CRAFT modality is widely used in adolescents between the ages of 12 to 21. TAD, Triage Assessment for Addictive Disorders. UNCOPE, it's 6-question assessment to identify SUD in broad ranges of populations. Some of the things that you can use and punt out for family members is Allies in Recovery website. That's for parents and loved ones. They teach CRAFT modality, how I talk to individuals, how I talk to my loved one, how do I heal myself, and really just finding that support group of individuals and people that understand. It's been so eye-opening and so helpful for me to feel like I'm not alone. People are out there and they do understand. I don't have to be isolated. And this group understands where I'm at. They understand when I'm struggling and it's hard for me to give empathy to my own child. Sobergrid.com is also something that you can utilize for individuals who are in your emergency departments or rural health clinics. It's a free peer recovery coaching 24/7. They can get it on their phone. It's an app. They can download it. Everybody has smartphones. This is something that's accessible to the individual who's dealing with substance use disorder 24/7. It's accessible to them. They're on their phone. It's an app. And it's a community there to help support them wherever they're at, whether they're in an ER, a rural health clinic, wherever they're at. In Indiana, we also have, you can call Indiana 211 by phone. You can get a hold of peer recovery specialist here. You can get housing help. You can get, I'm in crisis right now. I need somebody to get to me. It flags, EMS, it flags those individuals that can get to somebody and help them. Indiana 211 is a great resource. And then the link for all of these tools that I just listed here is listed in this PowerPoint that is through SAMHSA. And it actually gives you every single tool rather than taking all of these PowerPoint slides up to look at the tools individually. I gave you the link so you guys can look at it. Print, download at your leisure, which ones you want to use or which ones you don't. So the latest updates, I just briefly wanted to give you an update. As I said, I did talk to Katie Hokinson. Those of you might know who Katie and her team are. If you don't, they're the Division of Trauma and Injury Prevention at the Indiana Department of Health. These are their updates that they provided to me, what they wanted this group particularly to know, and the efforts that are going on at the Indiana Department of Health. They're doing naloxone education and distribution programs and grants. They also are looking at overdose fatality review programs. There's an overdose response project that's occurring, as well as syringe service and harm reduction programs. I did provide you email addresses and names if you want to link in with anybody to ask further about their programs. And there's a brief information over here in that second picture that you see. optin.in.gov is naloxone distribution across the state. If you want naloxone, you need naloxone, you're running out of naloxone, please opt in, get that naloxone so that they can get you that. There's grant money that's already there. It's already been funded. They already have the doses of naloxone. It's just sitting there waiting for you guys to opt in and say, I need some. I want to give them to every patient that leaves the ER so that they have their own personal naloxone. There's syringe service and harm reduction programs. We really think about that. Think about your thought processes around that. To be very honest with you, in one aspect, our society says abstinence is the key. Abstinence is the key. Well, that's easy, except it's hard for that person in the midst of substance use disorder to go completely abstinent. They become dope sick. My son refers to that all the time. Dope sick. I'm dope sick. If you ever understood what it was like to be dope sick, you would understand why abstinence is so difficult. Having those conversations, open that dialogue. What do you think about harm reduction programs? I would much rather my son be in a safe environment that I know that what he's getting isn't laced with fentanyl, to reduce his use until he decides that he can get to treatment, than to say abstinence, 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 abstinence. That isn't working. Let's open this dialogue. Let's open this dialogue from an emergency department perspective and a rural health clinic perspective. Let's be vulnerable. Let's have accountability. Let's pave the way for empathy and understanding. And then their latest is the Overdose Fatality Review Team and Overdose Response Programs. The Overdose Response Project, again, part of Indiana Department of Health. In 2017, IDOH received additional prescription drug overdose funding from CDC and under the Prevention Grant to implement a rapid response project The purpose of this program was to assure current county level capabilities and response readiness of local health departments and county stakeholders to overdose events. That includes you guys, emergency departments, rural health clinics. Grant applications were open to all LHDs in Indiana. Your LHD applied and were awarded. This was old data because this was from 2008, 2019. I haven't seen 2020 and 2021 yet. Grant recipients were required to use Essence, electronic surveillance system for early notification of community-based epidemics. That's a mouthful. Epidemiologists love putting all of these big, long words together. I can say that in the spirit that I work directly with the epidemiologist. Essence is used to identify emerging overdose trends and alert local partners of increased drug overdose activity. It's also used to identify communicable disease outbreaks. Guys, huge hepatitis outbreak related to this population, related to substance use disorder. IDOH has created overdose queries and routinely updates them. If you want to know more about Essence, please visit the link that I listed in this PowerPoint slide. If you're a member of a reporting hospital facility or local health department, you may also sign up for Essence account by contacting Kaylee Hum. I work directly one-on-one with Kaylee. I love her. She's a phenomenal human. And so for more information, please definitely check out this project and what IDOH offers and their updates. And with that, we have a special guest speaker that has joined our line. Becky, I will let you somewhat introduce Lori, unless you want me to do that. And then Lori, I'm going to let you introduce yourself as well so that we can hear from you.
I'll pause here just for a moment. So Allie, if you'll stop recording,